alert medications, well, it's supposed to be annual, but I think it was about 2 years ago when I gave this talk. Most of the drugs are the same. We have added a couple extra ones. So just to explain what the high alert medications are. So they're considered medications that bear a heightened risk of causing significant patient harm when they are used in error. So using in error means underdosing, overdosing, giving to the wrong person, etc. ISMP is the Institute for Safe Medication Practices, so that's a pretty popular site for institutions and pharmacies and to go to with regards to anything to do with medication errors, like sound-alike drugs. There's all kinds of good information on that website. So this is the definition that they give. The medications that we'll be including, the list is longer than what I'm giving you, but usually when I do talks at Harborview, I try to center them around medications that you guys would normally see. So the main ones are things like warfarin, Fragmin, medications called novel oral anticoagulants, so that's NOACs, which are the new types of blood thinners, Xarelto, Eliquis, Pradaxa. We'll also discuss insulin, oral hypoglycemics, narcotics, oral and subcutaneous, and methotrexate, finasteride, and any oral chemotherapeutics, which we don't see a lot up here, but I will touch on those. So the medication awareness, I just wanted to throw this in here. I guess whether or not we're discussing high alert medication, the elderly population in general tend to be more sensitive to side effects, or not just side effects, but the effects of drugs in general. So even though we're focusing on some fairly important ones that can be very toxic or have dramatic effects, any medication, whether it's like an Ativan or a type of blood pressure medication, can have adverse effects on anyone when it's given, especially the elderly. So we always need to be aware of what you're giving. And although there are much more than 5 rights these days, I just thought I'd put at least the minimum 5 rights that we always learned, years and years ago. Making sure that you've got the right person with the right medication, the right strength, the right route, and the right time. So just kind of, those are, I guess, the top 5 to keep in mind. There are others, but for this talk, we'll kind of keep an eye on those. So starting off, discussing warfarin. So warfarin is essentially a blood thinner. It's something to help keep clots from forming in the arteries, so to prevent heart attacks, to prevent stroke. Usually used when somebody has atrial fibrillation, so the top part of their heart is fluttering and it's not pumping smoothly, so clots tend to form. So warfarin actually is used to help stop that fluttering and help the blood move along more smoothly. Dosing varies between patients, and thus INR blood tests are required to establish a proper dose. So a dose for me would be different than a dose for Cindy or Wendy, perhaps. And when a person is started on warfarin, they're told to get their INR done usually within the first, if not first couple of days, within the first week, and then usually people will go weekly, and then as their INR seems to be pretty consistent, then they usually go monthly. So the reason I mention that is that everybody is a little different, and the therapeutic range, so the range at which you want it to have the kind of the perfect blood thinning, so it's not too thin and not too thick, and that it's doing its job, you have to be within this kind of tight ratio. So a very small change in a warfarin dose can affect that INR quite drastically. So having said that, again, keeping the importance of when we're giving a patient, say, or one of the clients, from stop use a warfarin, we require you to have 2 people checking the dose, and that's why, because it's such a sensitive thing. If you were to give the wrong thing, it can make quite a dramatic impact. Make sure that the resident takes their dose at the same time each day. So approximately. So most of the patients will get them in the evening, and that tends to be the main reason is because they're going to go for their INR that morning, and that way if anything changes, the doctor will usually notify a patient or notify Harborview of a change in the INR, and therefore the dose may need to be changed. So leaving that dose for an evening allows that to change, because if you take it in the morning and the INR is done, you've got to wait almost 24 hours before you make that change. And this way, usually you can do it quickly after you find out what the INR is. And missing or underdosing, again, can cause stroke or heart attack. Overdosing can result in a life-threatening bleed. So these things are very sensitive in how they work. So someone who needs to be on the warfarin, if you underdose them, they're not getting enough, then they do have the potential to have a heart attack or stroke. And then obviously if you give them too much, then it doesn't take much to, in the way they could fall and strike themselves, and you could get a life-threatening bleed from that. So you're going to refer to the nursing policy and procedure on anticoagulant therapy, which will give you the INR ranges and criteria for notifying a physician. You guys have standing orders that allow you to continue a dose if it's within a range, so that, I believe, is in that policy. Warfarin is packaged in separate PatMed pouches, basically because the dosing tends to change based on that INR. There are some people that seem to be on the one strength and it can continue for quite a while. There are other people that seems like every other week you're having to adjust their warfarin based on their blood work. So because those changes occur so frequently, we like to keep warfarins in its own separate pouch. So there's a second check required by registered staff when administering warfarin. And again, as I mentioned, warfarin when taken from stock must be checked by 2 registered staff prior to administration. So the newer blood thinners, the NOACs, N-O-A-C, those are the 3 main ones that you'll see here: the Pradaxa, Xarelto, and Eliquis. Like warfarin, they're used to thin the blood, to prevent strokes and heart attacks. Again, also using people that had atrial fibrillation. Unlike warfarin, you don't need to have that INR done every week or 2. So there's not this sensitive range. There's only a couple strengths of Xarelto, and based on the patient's kidney function and weight, usually they can pick the one that's right for them. Also, unlike warfarin, there's no antidote. So if somebody were to have had an overdose of warfarin, or maybe their INR came back and it was quite high, vitamin K can be administered to help try and increase the blood clotting, to block how the warfarin works. The tricky thing with the newer ones is there's no antidote. So if somebody's blood is too thin, you have to wait for it to come out of the system, which can be a couple of days, 2 to 3 days before it's completely out of their system. So that's something to be aware of with the newer anticoagulants, even though it's nice that you don't have to do that blood work very often. If someone is in a situation where they think that their blood is too thin, then they have to just wait it out and hope that they don't get a bleed. These are actually packaged with the other medications. They're not separate because the doses don't tend to change. So we can kind of put them in with all the rest of them. Low molecular weight heparins. We have seen some patients come up here on Fragmin. A lot of times it's after they've had surgery, if they've had hip or knee surgery perhaps, but we are seeing some people that are actually put on it as preventative maintenance. So you may see that coming up here at some point. There are subcutaneous injections at Harborview. It comes in different types, but we will always be providing the pre-filled syringes to Harborview. That way the dose that is requested is already pre-measured, which makes it a lot safer for administering, so you're not getting the wrong dose, rather than having to draw it up each time to give the dose. But it's usually given in situations where you want immediate results. So again, after surgery, when somebody is immobile, you don't want them to have any clots while they're sitting there or laying there immobile. So they'll give fragments subcutaneously to help bring on that anti-clotting factor quickly. And it's usually used short term, but again, as I mentioned, you might see it being used a little bit. Depending on the case, you might see someone come up here on it daily. Requires an independent double check verifying the resident's identity and the medication. So that's important. Obviously, you don't want to be giving the wrong person a shot of Fragment. Again, that is probably something you should always be doing no matter what. But again, if you're going to give somebody a subcutaneous shot of Fragment, that's going to thin their blood pretty quickly. So you want to make sure you got the right person. Moving along, insulin. So insulin is a hormone used to help transport glucose into cells for energy. So insulin is produced by the pancreas and is floating around the bloodstream so that when you eat something sweet or eat anything that gets broken down into sugar, that sugar is absorbed into the needed tissue like muscle, brain tissue, different organs using the insulin. The insulin's like the pathway for the sugar to get into the organ. If you have too much sugar in the bloodstream, so not enough insulin, you can get a lot of chronic issues over time, like blindness, kidney failure, and because of poor circulation, you might end up with possible amputations. But too much insulin is probably a scarier thing in this environment because it has more of an immediate impact. So if somebody's got too much insulin, then their sugars are going to drop very quickly, and which can lead to dizziness, fainting, or coma. The dizziness and fainting is something you don't want in a nursing home. That's going to increase your chance of falls. So having said that, giving insulin should always be accompanied with people eating. I think we had that talk not too long ago that patients who are not well and they're not eating, there should be discussions about holding off on any insulins given. If they're not eating and you give them insulin, it's going to probably cause them to go into hypoglycemia, which again is more of an immediate concern. So the dose of insulin must be checked by 2 registered staff. Also important to note, if insulin is administered by the resident's intake is not adequate, hypoglycemia can occur quickly. So that's what I was just saying about they're not eating, probably not a good idea to give them their quick-acting insulin, or there again may need to be an adjustment, which would probably be a decision made by the doctor. But again, staff need to be made aware if the patient is not eating like they normally would be. And be familiar with the signs of hypoglycemia, which should be located in the policy for administration of insulin. And I just threw this up here, although it's not a life-threatening issue, it's important to rotate the sites of injection of insulin. So when you're giving it in the abdomen, you should always kind of be rotating so that it's not always going in the same place, because it'll cause something called lipohypertrophy, which is basically fat cells that build up and cause these nasty lumps because it's doing tissue damage every time you go in to that same area. And then again, injecting into those sites that are already like scar tissue, you won't get the same effect out of them as well. You won't get the same effect out of the insulin. So oral hypoglycemic, so these are things like gliclazide, glyburide. They help the pancreas to release insulin. So in a way, we kind of think of them as very similar to insulin. So because your body's going to create more insulin. So again, the issue is if you're giving something like this to someone who's not a diabetic, or if they haven't eaten, and it will cause their blood sugars to drop, which can increase their risk of falling. So again, it's still important to monitor residents' intake and watch out for signs of hypoglycemia. So not just your residents that are on insulin, but also those that are on hypoglycemics. These also require an independent double check, verify that the resident's identity and the medication being given. Narcotic analgesics. So this is hydromorphone. You've got fentanyl patches, you have morphine. The hydromorphone comes up as tablets and injections as well. These are centrally acting pain medications. So not only do they control pain, that they can also, cause drowsiness, dizziness, and increased chance of falls. In the geriatric population, they don't require a lot. So giving something like that to someone who's also never had a narcotic painkiller before can be quite dramatic for them. They can show a lot of those side effects that I mentioned, like the drowsiness and dizziness, quite quickly and quite intensely if they've never had that before. So again, making sure you've got the right person in front of you is very important. But also making sure that you're dosing, you're giving the dose that's on the MAR sheet. If you give an extra amount, that little extra amount can be quite detrimental to someone in this age group.
Mike, quick question. Why do you say the geriatric population do not require much pain control?
They tend to do better on less hydrogen. So it's just the fact that their bodies don't break it down quite as quickly as I would.
They still get pain though.
They don't require as much medication.
As much medication.
Okay.
Sorry, not as much. Yeah, it's not that they don't require more pain control.
Okay.
They don't require as much medication to achieve.
To have pain.
That's right.
Okay.
Sorry.
Yeah.
So they just
Lady's
don't.
dying.
That's right.
She's aspirated.
That's a different issue.
So you have to be careful about missing a dose as well. So these people, again, they're sensitive to too much, but if you don't give it to them, again, they're going to have issues with pain and distress. So missing doses is not a good thing either when you've got someone who's got chronic pain. So those are the HVH stocks, the hydromorph, fentanyl patches, and morphine. They require an independent double check verifying residents' identity and the medication before administration. So moving along to methotrexate. So this is a type of disease modifier. It basically impacts your immune system. So if somebody has psoriasis or rheumatoid arthritis, or they can also use it in different types of cancer, but for here, we mostly see it with people with rheumatoid arthritis because arthritis, in a lot of cases, tends to be, it's your body attacking itself. So your own immune system is causing the issue. So the methotrexate dampens that so that your body is not doing that. Having said that, people who are on methotrexate do tend to have weaker immune systems because of the drug, and therefore are more susceptible to getting ill from viruses or bacteria. So you have to be very cautious around people that are on drugs like that. The big issue with methotrexate is it's very toxic. Usually blood work for liver function tests need to be done. And the big issue, because it's given usually weekly for rheumatoid arthritis, there tends to be an issue where someone will get it once a day. We've had it happen in retail, we've had it happen I think here as well, where the patient has their dose and then unfortunately the next week they get it as well. I think on the MAR sheets, I've got it now that it X's out all the days that you shouldn't give it, so at least that's a help that kind of denotes that yes, it's only given once a week. But it can be very toxic. Again, so you're talking about the immune system, so if somebody's supposed to get this every week and they get it once a day, they can become very ill very, very quickly, and it can do quite a bit of damage to your liver as well. Care should be taken when handling methotrexate. So again, anybody who is pregnant or maybe become pregnant, thinking about getting pregnant, may not want to be handling it, and they should be wearing gloves when administering and washing their hands after. They're just worried about absorbing any of the drug on the skin. So they also want you to avoid crushing and breaking, if possible, to avoid breathing in any of the powder as well. So for that reason, we've got this drug packaged separately in blister cards so that you can just deal with that. You don't have to be fidgeting around looking for that pill in the pack med. That drug is kept separate completely. Similarly, the finasteride. So this is a drug that's used to treat prostatic hypertrophy. So when a man has an enlarged prostate, finasteride is usually used to block testosterone that causes that extra testosterone that causes it to enlarge. So again, you don't want pregnant women messing around with a hormone like that, or something that can block, even though I guess technically women do have some amounts of testosterone. The drug itself can cause birth defects, so we just want people who are pregnant not to be handling them. Doesn't quite have the same issue, even though it's the same precautions as methotrexate. With crushing, it's not really toxic, it's just, again, you don't want to be necessarily breathing this stuff in, so we just in general say use the same precautions as you would with methotrexate. So oral chemotherapeutic agents, we don't see a lot of that at Harborview, but if we do come across any, you'll be seeing some labels that say cytotoxic use precautions, in which case you'll handle them again similarly to methotrexate, avoiding skin contact whenever you can with wearing gloves, disposable medicine cups, washing hands thoroughly. Don't crush if you can avoid it, but dispose medicine cup and gloves in the cytotoxic labeled sharps containers. You can also refer to the Nursing Administration Policy Administration and Safe Handling and Disposal of Cytotoxic Material, which will tell you more about what you should not be doing with it.
For
Again,
those of you, we did this actually up here with a lady back a while ago. Most of you weren't here, Amanda, you would have been here. Yeah. Yeah, we had.
So you did have something that was
Yeah.
cytotoxic. So on the MARS, all these meds that we've mentioned will have the words high alert, the little stars beside them, to indicate that the medication you're dealing with is a high alert medication. The PACMed containers should also have a yellow sticker to denote that there's high alert medications in those pouches. And insulins would be kept in yellow trays in the refrigerator, just again, that yellow reminder that it's a high alert medication. And that's it. Very brief. And I will find out about the Xeljanz. It's
Yeah.
a great
it's
question.
pretty
It is a
sure.
disease modifier, but I don't know that it's considered
that?
quite like
Any question?
methotrexate is, but.
Now, I think I may have called you guys about crushing it, but thinking of from the perspective, is it okay for her to take it that way, but not thinking that,
Of the people dealing with it.
yeah.
Yeah, okay, yeah. I shall look, because if that's the case, then we need to be packaging them separately, but I feel like they're not. I feel like they're not quite
The same.
in the same category, yeah.
Does Mrs. Grow take hers crushed or not crushed? Her pills typically.
Cool.
Your Michelin.
She takes them home.
Oh. Hers will be an issue if we ever have to crush hers.
Yeah.
She is on methotrexate.
So that you can't,
Something to
yes, you'll
keep
have
in
to
mind
take,
for
exactly,
me.
you'll have to take extra
And we'll have
precautions.
to